So next up, we have Dr. Michael Rimmer, who's a clinical research training fellow based in Edinburgh. He's also the chair of the UK Audit and Research Collaborative in Obstetrics and Gynaecology, so among many other things. So I'll leave it over to you, Mike.
Thank you. First of all, I'd like to say how excited I am to be here today, and thanks to the BUSOG committee for their very kind invitation to speak at today's event. I think it's been a really great event to hear so many different perspectives, and I've been asked to briefly talk to you about how things have changed across the NHS during the time of COVID and for pregnancy in particular. And I'm just briefly going to speak today about some of the work which the UK RCOG have been able to do in looking at this. So I'm just going to start my presentation now. So I'd like to begin by saying I've got no financial relationships to disclose, and I thought I'd begin this talk by going over a brief timeline. I think it's important to recap events as they can often blur into one, and I don't know how other people feel, but I think through lockdown, through having been redeployed back to the NHS, things tend to blur into one. So this all actually started on the 31st of December 2019, when the Wuhan Municipal Health Commission reported 27 cases of a viral-like pneumonia, which was potentially linked to a live animal market, but they were of unknown cause. And the next day, the Wuhan Municipal Health Commission decided to close that market due to ongoing concerns that this may spread. And on the 9th of January 2020, the Chinese CDC reported the first cases of a novel coronavirus causing this pneumonia, later to be called SARS-CoV-2. On the 20th of January, the first cases were reported outside of China, in Thailand, Japan and South Korea, and this was then later followed by first case in the United States. A day later, Wuhan City went into lockdown in an attempt to contain the spread of the virus, and also one day later the first case was reported in Europe and Germany. On the 30th of January, the World Health Organization declares coronavirus a public health emergency. And as we've just heard, on the 9th of March, a few weeks later, the RCOG issued its first specialist guidance for the care of women with confirmed or suspected COVID. And on the 11th of March, the World Health Organization declares Covid-19 to be a global pandemic. And on the 23rd of March, as I'm sure we all recall, the UK enters lockdown. So when we entered lockdown, NHS services were reorganised on an unprecedented scale. And this was in anticipation of a sharp rise in the patients requiring respiratory support and perhaps even ventilation. And this led to significant redesign of both current infrastructure, but also the rapid expansion of new healthcare facilities. The most famous of which is surely these Nhs Nightingale Hospitals, which are set up around the UK and ready to respond to the anticipated surplus in demand on the NHS services. This was both to provide intensive care facilities, but also step down and rehabilitation facilities too. There was also a feeling that there was insufficient equipment available across the NHS to meet this rise in demand, and this in turn led several companies turning their efforts and innovation to develop new ways to produce this equipment, in particular ventilators. And as well as these massive changes in the infrastructure, a lot of staff were redeployed to acute areas. So I myself had my PhD put on hold for 5 months and was redeployed from my university position back to the NHS working in obstetrics and gynaecology. And this was a common theme throughout the UK as clinicians working in non-patient facing roles were redeployed across the UK, again in anticipation for what might come. But what about the NHS services which cannot stop and which must continue regardless? This is especially relevant to women's healthcare services, as they're often acute and in continual demand, as we've heard today. And this led to many people to worry about how we would continue to provide a high standard of care to women during the Covid-19 crisis. Now, it's important to remember this wasn't just purely speculation or misplaced anxiety. In other recent epidemics such as Ebola in 2014-15 and also the swine flu pandemic, or more formally known as influenza A virus 2009, adverse outcomes in women's health were seen across the world during both outbreaks, which rightly so legitimised the concerns of many healthcare leaders, patients and providers in the UK. Regrettably, we've already seen that some of these concerns have been realised, and a similar trend of poor health outcomes in women during this pandemic has been seen. A recent study in the Lancet Global Health looked at the stillbirth rate across 9 hospitals in Nepal, and the authors identified a rise from 14 stillbirths per 100,000 to 21 stillbirths per 100,000. That's a 50% increase. And this was most pronounced during the first 4 weeks of the lockdown report, where people were restricted to only leaving their homes to either buy food or receive essential care. And recently, a similar finding was also reported by UK researchers based in a single hospital in London. And we anticipate that over the coming months and years, we'll start to slowly realise the full impact that Covid-19 has had on women and their health outcomes. To try and combat the unknown and inform clinicians how best to care for women with suspected or confirmed Covid, the RCOG, in collaboration with the Royal College of Midwives and the Royal College of Paediatrics and Child Health, developed guidance which has been updated throughout the past months and is currently in its 11th version, as we've already heard. It's a wide range and includes important aspects such as antenatal care, care during labour and delivery, and postnatal care, and importantly, how to manage a woman who's clinically deteriorating and has suspected or confirmed Covid-19. But how is this guidance being implemented, and were there any variations in provision of care for women across the UK? So we wanted to try and understand what was going on. And so the work I'm going to speak to you today was some work done by the UK Audit and Research Collaborative, and it's evaluating the provision of Obstetrics and Gynaecology Services during the acute phase of the Covid-19 pandemic. We undertook an interview-based national survey of junior doctors working in healthcare services across the NHS, and using the national network of the UK RCOG, or the UK Audit and Research Collaborative in Obstetrics and Gynaecology, it let us really reach out to across the UK to speak to as many trainees in as many units as possible. We contacted 155 training units across the UK, and we received responses from 148 units, which equates to around a 95% response rate. And we were able to develop the survey and reach out and receive these responses within a 2-week period. We used a mixture of open and closed questions covering training and support, labour ward care, antenatal and postnatal care, benign gynaecology, and gynaecology oncology. I'm going to speak to you very briefly about some of the findings. So how have the services actually changed across the UK? Well, with regard to labour ward in particular, dedicated operating theatres for patients with confirmed or suspected Covid-19 were reported by 70% of respondents, and clear local protocols for the care of a woman with Covid-19 was reported by almost 90% of units across the UK. Around half of these units had modified their induction of labour or elective caesarean section pathways, mostly by offering outpatient induction and also the mechanical induction with the Cook's balloon, as we heard from our first speaker. And importantly, over 90% of respondents reported they had sufficient access to PPE on the labour ward. And it's very important just to point out that when we did this survey, this was right at the start of the pandemic, and I'm sure that the access to PPE on labour ward is now almost 100% across the UK, and that's certainly been both my experience and experience of many of our members across the UK. In terms of the changes that we've seen to antenatal and postnatal care, we saw a reduced attendance at hospital by offering telephone clinics, and also a reduction in the number of antenatal visits required. We also saw changes to the way the antenatal screening pathways were being delivered, and this mostly referred to GDM screening, or screening for gestational diabetes. And interestingly, almost 80% of units had dedicated areas of the hospital for which they could care for women with suspected or confirmed Covid-19. And this doesn't mean they'd be sent to ITU. There were dedicated labour ward rooms, adequate PPE and protocols, and the right training for staff to be able to care for a woman should she present in labour with symptoms or a confirmed test of Covid-19. In terms of benign gynaecology and gynaecology oncology, we reported that all elective and fertility work had stopped by almost all units in the country. And modifications to the 2-week wait referral pathway were reported by around 40 units. Around half of hospitals in the UK had a reduction in the number of oncology theatre lists they were running, and 1 in 4 units had moved their oncology operating to a different site in an attempt to shield these high-risk, highly vulnerable patients who cannot delay their surgery from the risk from the general hospital population. In hospitals where they were unable to move to a co-located site, we found that around 25% of units had changed the location where their oncology patients were going to be cared for. Again, this was in an attempt to shield these high-risk patients. But what did our trainees think? We've discussed some of the responses from our closed questions, but we also invited open responses too. So I'm just going to play a brief slideshow of some of the responses we received from trainees across the UK, and these are all available as supplementary material in the paper. I think we can see here that the responses are very mixed around the UK, and we think this is likely due to regional and hospital variations in practice, but may also be influenced by how badly affected their particular area is. In perhaps more rural areas with very few cases of COVID or low suspicion, maybe perhaps in smaller maternity units which don't carry out advanced oncology care, the impact may not have been perceived to be as bad as those perhaps in the larger London trusts at the height of the pandemic. But how are we doing? Well, I think it's important to acknowledge that this was an unknown, but there are also things that we did know about. So we know that women's healthcare does suffer during pandemics, and we also know that women do suffer from domestic violence. There are those at risk of social isolation, and I think it's important that we don't just say, oh, we're worried about coronavirus, patients can't come into hospital. We do need to take these things into account. So it's important to remember that not all antenatal care can be provided over the phone or telemedicine, and this does adversely affect those at risk of social isolation, mental health issues, domestic violence, and also those with limited access to this technology and those who maybe don't speak English as their first language. We also noticed that significant changes to oncology services were reported, but there's going to be some major challenges in the future in how we are going to manage the current demands on oncology services when we restart non-urgent surgery. Many staff who were also redeployed into the NHS have returned to their previous university or teaching roles, leaving fewer staff to address the backlog of cases which have built up. And there's currently no substantial plan as to how we'll manage this, although this may be addressed locally rather than nationally. And the system is already strained, and there's far fewer staff to continue to provide the care that's required, which in turn may lead to poor outcomes for patients, especially as we enter the winter months. We submitted our work for peer review, and it's been published in the British Journal of Obstetrics and Gynaecology in May. There's a copy of the top of the paper. It's published as open access, which means anyone can read it without needing any special access to the journal or institutional logins, and it's there for anyone to read. So I'd encourage you to take a read of it if you're more interested in this work. It's just interesting actually, while I was putting this talk together, and I remember writing this paper, and I remember I logged on to the World Health Organization website to look at how many people had been infected with COVID, and this was published in May. And at that time there were just over 3 million confirmed cases of Covid-19. And I checked again last night, and currently there are over 30 million. So this is an extraordinary tenfold rise in the number of cases in only 4 to 5 months, and clearly presses upon us how this is an ongoing issue which we must prepare for. And so during this significant upheaval, we saw huge support for frontline workers, and arguably best summed up by the weekly clap for carers, which ran from March to May this year. But also in addition to support from the public, major investment from UK healthcare research funders was redirected towards Covid-19, with the development of a Covid-19 vaccine currently recruiting to phase 3 trials. More importantly, however, is the provision of this vaccine should it be deemed effective. And presently, over 2 billion doses have been committed to by various manufacturers across the UK, Europe and Asia and the US. And as a result of lockdown and reduction in the number of cases, the NHS services have begun to plan how they can reopen while still providing safe care to patients, but while limiting the spread of the virus. During this time, and certainly more recently, we've begun to see how healthcare services are beginning to reopen. And it's been noted, however, that the significant reduction in elective and non-urgent care over the past few months has created somewhat of a backlog. And the NHS has got some really difficult decisions coming up in the future months as to how we best address the needs of patients while still ensuring acute and urgent care needs are met. However, a reduction in the number of COVID-19 cases due to several countries enforcing state lockdown, as well as global travel restrictions, will surely begin to see a return to life as normal, and maybe return to the status quo for healthcare services and for women's healthcare services in particular? Sadly not. As national lockdowns begin to ease and restrictions on social gatherings have relaxed, we've seen a rise in the Covid-19 cases, with stark warnings from the UK Chief Medical Officer and Chief Scientists. In particular, a warning that the UK risks a substantial rise in Covid-19 cases and hospital admissions should urgent action not be taken. And this has been associated with tight restrictions across Europe and will make many pause for thought in how we manage healthcare services moving forward. And we need to give serious consideration as to how we'll continue to provide acute and urgent care for women, whilst also ensuring we meet the needs of less clinically urgent but still important health needs of the many patients out there. We also need to consider how we're going to innovate and find new ways to tackle the health inequality that women in particular face during this global pandemic, and with anticipation as we wait for a potential vaccine. Thank you very much for your time. I'd like to say thank you again to the organising committee for their kind invitation to speak today, and to everyone who's joined us online to come and listen. I'd also like to say thank you to all the key workers and frontline NHS staff who've been working in our public healthcare services during the past few months. You've been absolutely amazing. Thank you very much.
Thank you so much for that. That was so good and lots of really interesting information for everyone. The top question at the moment is, do you think that the obs and gynae sector of the NHS was prepared for the impact of the pandemic, and what lessons can be learned for facing the winter months?
I think we were relatively well prepared, yes. As we've heard, the RCOG sprung into action very quickly, both as the main provider of guidance for women's healthcare in the UK, but also one of the main providers globally. And as we heard before, this guidance takes years to develop and was put together very, very quickly. I think in terms of lessons learned, I think at the start there was general fear of the unknown. We didn't know how infectious this virus would be. Would there be vertical transmission from mother to baby? Would pregnant women be adversely affected? And so you may recall that pregnant women were advised to shield as a vulnerable group. And thankfully, in my experience, clinical experience at least, we've not seen many women affected with Covid-19. We've not seen many poor outcomes either. I think it's short-sighted to only look at the immediate outcomes and focus only on Covid-19. It's important to remember that women aren't accessing healthcare services as much as they would usually, and therefore this may be seen by a rise in the stillbirth rate, potentially an increase in domestic violence, and often what is seen as hidden health inequalities, but we know affect women disproportionately more than men. And I think it's important that going forward we really need to think how we do try and combat that. And I don't necessarily know what the answer is, but I think it's something that we need to engage with all our service users and with the Women's Network and the college and clinicians and other healthcare services to think how we can best address this change.
Perfect. The next question is not really a question, it's would it be possible to have the slides available afterwards to view, to look again at the links and data?
Yes, absolutely, and the papers are available online should anyone wish to look at that as well.
Perfect. So the next one is, has there been much of an international collaboration with improving O&G care during COVID?
I think there has been, because we're very keen to learn how other countries have adapted their services. It may not be that publicly seen, but there's definitely, as far as I'm aware, we've looked at how other countries have responded to this pandemic. One of the things that we know is that women's health outcomes are adversely affected, and we've seen that not necessarily just through what's happened in the UK, but from previous things like the swine flu virus and the Ebola virus, and that isn't just the UK, but that is the UK looking outwards to other countries and see how they've managed these things as well. Molly, your microphone's switched off, I can't quite hear you.
That's my microphone that's the problem. How has the research in O&G been affected? Are more papers being published on COVID than other areas? And are there any barriers for research in this time?
So I think obs and gynae research has gone through a bit of a rocky patch in that when COVID first became a thing, and I know I received emails from HEE West Midlands asking me would I stop my PhD and would I be willing to be redeployed back to the NHS, and I said very happy to go, ready and willing. I know a lot of clinical trials were put on hold due to reduce the number of patients attending hospital. I know that a lot of basic science research also has to be put on hold as people weren't allowed to go into the labs, but I think that was for research across all specialties.
Okay. This is from Jack. Has there been a study looking into the impact of COVID-19 and how O&G specialty training has been affected? What's your opinion on how these things may have been affected?
As far as I'm aware, there hasn't been a study directly looking at O&G training. I know the European Network of Trainees in Obstetrics and Gynaecology have looked at how COVID has affected training across Europe, but there's been no formal study on this as far as I'm aware. Anecdotally, I know that a lot of gynaecology is elective, and so smaller procedures that a trainee might get to do, like a hysteroscopy or attend an outpatient clinic, has all been significantly reduced. We've been only continuing with major gynaecology, oncology services. All fertility and urogynecology work has been scaled back massively, and we still face issues in where we're having to decide which patients we let into hospital in an attempt to reduce the number of patients attending hospital and limit the risk of bringing the viruses into the hospital. This will almost certainly impact the non-emergency aspects of obs and gynae training. I think there'll be no shortage of how to manage on the labour ward and cesarean sections and instrumentals, but I do think this will potentially impact on perhaps your minimal access gynaecology training. And I'm sure, but I know that the college and many training programme directors are looking at how we can build up the skills lost during this time.
Perfect. What are the major research questions that you think are yet to be answered about how COVID-19 affects pregnant women and neonates?
That's a very big question. In terms of the major research questions, I guess one of the main issues which will face us very shortly is, will the COVID vaccine being developed in Oxford, will that be as effective in pregnant women? There's no reason why it shouldn't be, but as a rule of thumb, we are very cautious when we introduce new medications to pregnant women. So I guess if you had to say what will be the biggest area of concern, I think that will be, will pregnant women be affected at all by the COVID-19 vaccine? I think it's unlikely, and I would encourage them to partake if they felt it appropriate. But I think that will be a major question for any new medication that's being offered to pregnant women, presumably on an international scale.
Perfect. Following on from that, with the Russia vaccine, is there much of a collaboration on that front with sharing information about how the vaccine is impacting different groups, or is that kind of not really an area of collaboration yet?
So I am not a spokesperson for the UK or Russian governments in terms of vaccine collaboration, but I'm very sure that through the World Health Organization and the European Centre for Disease Control, just named two major groups, I'm sure there'll be huge international cross-collaboration. As I briefly discussed, over 2 billion vaccines have been committed to by various groups across Asia, Europe, the UK and the United States. It's important to remember as well, there's more than one way to skin a cat, and although we may see the University of Oxford and say, well, this is a vaccine we're developing in the UK and we trust our own healthcare resources and facilities, I'm sure if just as good as vaccines developed in Russia, I'm sure there'll be huge collaborations to ensure we get these medications out for as many patients as possible, as quickly as possible.
Perfect. Sorry, I meant within research communities, not governments. Don't worry. This is more of a career-y question, but it's about what opportunities do you think there are for medical students to become involved in O&G related research, and how can we go about this to highlight quality issues and improvements in maternity care?
I think there are a lot of opportunities for students to get involved. I think it's important to get involved in a robust project. So if you speak to BUSOG or come speak to me at UK RCOG, we often run some national research projects which we aim to present and publish. The RCOG also offers a lot of prizes for medical students who've been involved in research, and often these prizes are only open to medical students. Again, it's something that's not very well known, but the college really does promote research at all levels of training. You can undertake an intercalated degree, as I know many universities offer. I was fortunate enough to be able to intercalate during medical school, and it's actually the theme of my PhD, actually 8 years later. And I would really encourage you to maximise your exposure to obs and gynae related research through your clinical placements. It's often a myth that you need to be in a large tertiary centre. This is not true. A lot of research goes on in district general hospitals as well, and I would really encourage you to drop an email to your professor of obs and gynae or some of the clinical research fellows if you'd like to get involved in something. And that's how I first got involved. They will normally offer you quite a small project to test the water, make sure, not to overburden you, but actually if you deliver on that and you're enthusiastic and want to do more, they're often very willing to include you in larger and larger research projects.
Perfect. And I think a question that would be good to finish on is what is your biggest obs and gynae related takeaway from the last few months, and how will it inform your future research / practice?
I think one of the biggest things I've taken away is the ongoing importance of teamwork and multidisciplinary team working. Personally, I'm an English trainee, but I'm up here in Scotland. I was redeployed back into Scottish NHS, in a hospital I've not worked in before, and it was only through having lots of midwives and nurses saying, this is how you do it here, this is how it works here, and the other trainees taking under their wing, that I think we've really been able to work effectively within the NHS. And I think it's always important to remember that there's a patient at the centre of this, and it's only through the teamwork and the very diverse and vast range of skills of all the healthcare professionals available that I think will be how we will successfully meet the challenges that the Covid-19 virus is currently throwing at us.
Okay, thank you so much. Where can people find you online, if they can?
I am on Twitter, and my email address is on the paper. You're very welcome to contact me. I can go back a slide, or you can find the UK RCOG on Twitter as well.
Okay, perfect. Thank you so much. For everyone else, thank you